Welcome, everyone, and we're so thrilled to have you join us today for the first of our summits for 2024. The Association of Women in Rheumatology is pleased to welcome you to What's New in Vasculitis, Evolving Guidelines and Treatment Approaches. So our agenda today is, as you see on the screen, we'll have our welcome remarks, followed by our product theater, focused on RA data, including TNFi non-responders, and that is going to be delivered by Dr. Laura Amaris, coming to us from the Northeast, just northeast of me, sponsored by AbbVie. And then we'll follow that with our CME session, What's New in Vasculitis, with Dr. Rennie, Rhee, and Dr. Puja, Mehta. And at the end of that, we'll have our closing remarks and questions and answers that we'll go through for the entire program. So this is going to be a delightful event. I just want to make sure that no matter where you are, if you're live at a watch party or virtual, you're already on the app, make sure you log into the conference app, which now actually is either available in your browser or as a separate app. You'll be able to do all of your live polling, see the speakers, the sponsors, claim your CME, everything is there. But most importantly, at the bottom left, you'll see that Q&A button. That's where you type in your questions, and we'll be able to read those out to our presenters to answer live. So feel free to put questions in as you go along so that you'll be able to join us for that. And then as we move forward, I want to make sure that you're able to access and claim your CME. There's a button that you see here highlighted in red that says Claim CME. If you haven't done the pre-test yet, do it now so that you can have your pre-test questions in. You'll be able to complete all of those surveys, and then you'll actually be able to go and claim your CME. We'll remind you of this again, but you'll be able to claim the CME. And as a reminder, you can claim it up until April 23rd, 2024. So this is only available for 1 month. Please do not wait until 35 days to do this, but you can access this through the 23rd. Really want you to be able to get the benefit of having your CME. So now as I go into the opening remarks, I will be joined by Dr. Rhee shortly, who's going to walk us through some additional details. But to introduce you to who AWIR is, this is the AWIR board. We are a group of just dynamic, powerful women, as I will say, in purple, 11 board members scattered across the United States, coming from multiple different ancestral lineages. And we're just really thrilled to be very inclusive of everyone and really sort of highlight our diversity and inclusivity as well. We're thrilled to have our 2024 corporate sponsors shown here, our Amethyst, Sapphire, and Emerald, and it's no mistake that Amethyst is purple. So if you haven't figured out our brand color, the theme here is purple. So we thank our sponsors for supporting us in our mission with AWIR. And for our summit, we have our magenta sponsors here with us today, both AbbVie, Commercial and Medical Affairs, Pfizer, and UCB will be joining us at a later summit. We thank them for their support. And then our local chapter sponsors, we'll see throughout the continental US, we have multiple local chapters, and these are the sponsors. Again, thank you for supporting us with that. And as you see here, in purple are the states in which we have local chapters, and we have 50 chapters across 29 states and Puerto Rico. And I'll show you our global chapters. And what's beautiful here with our local chapters is you get together, you can get together, network, mentor, and lead and become a leader on either a local or regional level. And attendance is free here. And of course, yes, we love purple, but you can come in blue, pink, or red. We don't care. We just want everyone to feel welcome and invited. And in fact, highlighted here are the new chapters that were just formed in the past 15 months. And you'll see here local chapter leaders across the US. And these are our new local chapter leaders. And we want to acknowledge and thank them for their support. I know that we have people watching from all over the world, and we have global chapters and partners in multiple zones here from Australia, India, Bangladesh, Pakistan, Italy, Brazil, Puerto Rico is coming as both global and local. The Caribbean region and Canada joined most recently as well. And here it really is it's fostering our mission of the advancement and education of women in rheumatology and connecting rheumatology clinicians across the world. This is not exclusive to women only, because as we know, if you uplift the women in a community in any economic system, you end up sort of serving the needs of all. So this is really our avenue to serve all of our providers around the world. And in fact, we have members in more than 80 countries spanning 6 continents. And if somebody finds me a rheumatologist in Antarctica, we will have covered all 7 continents. I'm open and ready to do that. And as we continue to map across the world to turn this entire map purple, if you're in one of these zones, become a member and we'll add your color, your country to the purple color. Now, it is really easy to become an AWIR member, and we've decided a long time ago, as we committed to having an open entrance, that it's a one-time lifetime registration. You can scan this QR code, or you'll see the URL on the bottom, and we encourage everyone in the rheumatology community to join. We also have membership for our allied specialty members, just recently adding our internal medicine and family practice physicians who collaborate with us on the care of our patients, who often come in with multiple comorbidities and complexities. And so we welcome our fellow specialists who help us co-manage our patients to join as well. Now, what are the resources that we have available? There are a vast number of things that we have, but just highlighting some of the initiatives that really benefit everyone. We'll start off with advocacy. You'll see that we were just live on the Hill fighting for issues that are pertinent for our providers and our patients. And we do this both virtual and in person. So if you're interested in advocacy, Dr. Mehta, our champion of advocacy, will be happy to get you trained and out there so that we can make sure that we learn in whichever region we are in to be able to put forth our voice, amplify our voice for our patients. We are committed to education, and this is why we're here today, supporting physicians in advancing and developing the practice of rheumatology and supporting all of the other providers in the space, whether you're a physician assistant, a physician associate, a nurse consultant, a nurse practitioner, however you contribute. We also have registered dietitians, physical therapists. There's lots of people in our village as we care for patients, and we all need to understand all of the issues surrounding our patients. And then we also have a research arm, clinical research, in which we partner to answer some of the interesting real world questions that impact our ability to deliver care and the outcomes that our patients may experience. So again, lovely things that we can do together. And here, just to show some samples of what happened on March 13th, just 10 days ago, as we had our in-person Hill Day, really advocating for support of the Safe Step Act, holding legislative briefings. We'll see here that we met with 20 congressional offices and participated in stakeholder coalitions across this, across multiple venues. So go to our website and you'll be able to see a lot of the things that we do for advocacy. So committed to fighting for us as providers and our patients as well. There is a training program in advocacy because we do realize that as trainees, many, if not all of us, were not trained in how to advocate. And so this training program actually is CME accredited. It's free for all. And we're really sort of focusing this on our trainees, but this is for anybody who needs training. And the whole goal here is to increase awareness of advocacy and build confidence and establish a pathway to being a lifelong advocate and a lifelong activist for patient care. So that is our ultimate goal here at advocacy. As I mentioned, research is critical, and this is one of our most recent publications in ACR Open Rheumatology, really hot off the press, getting a little cooler, but we have others coming along. So join us if you're interested in joining in some of our registry and data set research initiatives. Reach out to Dr. Carr, you'll see her on the website. And then starting last year from our immunology bootcamp, we have 2 free on-demand programs, part 1 and part 2. You'll see here, you can scan those codes. They're also on the website. And each of these gives you a 2.5 CME and MOC credits recorded at our AWIR 2023 and covering some important immunology pathways that I think will help us understand therapies that are either currently in play or in development for our patient care. So feel free to log into that. So now we see we're looking at our Summit Series of 2024. And here we actually have 3 this year. We've gone from 7 to 5 to 3, really sort of consolidating our time. And the first one here is looking at clinical competence. What's new in vasculitis, evolving guidelines and treatment approaches. And then September 14th, after our annual conference, we'll go to cultural consciousness, looking at lupus as a broad topic, advancing evolving evidence to overcome healthcare disparities. And there we'll have both adult and pediatric rheumatology engaging in a lively discussion about care of our patients across the spectrum of their life journey. And then we'll conclude in December with a collaborative care where we bring in dermatology. We do so much in common with dermatology, looking at cutaneous conditions in rheumatology, a look across skin colors and pigment-rich skin. So how do we make this? How do we not miss it? What are the various issues that are unique that we need to consider? So the QR codes are there. You can scan those or just go to the website. And then you see all this purple. This is our annual conference. We've moved from August to July to make this a bit more accessible to many. So July 25th through 27th, Thursday through Saturday, join us at the Gaylord Palms Resort and Convention Center in Kissimmee, Florida, just outside of Orlando. And you'll see there that what we do is, yes, we work intensely, we learn, we connect, and we have tons of fun. So come and network. This year, we're rolling out on-site workshops where we'll look at ultrasound technology, imaging, nail fold capillaroscopy, social media branding for clinicians, just a new and evolving and ever-present need for us. And then look at some of the legal challenges in risk management. We'll be tackling this in respect to artificial intelligence, which is already in our world, and then entrepreneurship in clinical practice. So lots of opportunities to earn CME credits and also really get some practical, useful advices. And in the middle of this, if you bring your family, guess what? There's tons of things for them to do. Yes, it is Florida. It will be beautiful, sunny, and warm. There will be no rainstorms. We're just going to say that and drop that in there. But bring the family and, we can have fun and we can learn and we can still bond with our family together. There's no rule that says you can be a doctor only and not be a mother, a father, a child. So, we welcome our virtual attendees. This is always a hybrid conference for us. Many cannot travel, although we do want to say that there is a value to showing up in person. And I'm going to invite Dr. Rennie to the stage right now to talk through why she thinks this is such an important thing for us to be able to do, to meet and to connect that sort of, person to person bonding that can occur. So Dr. Rennie, invite you to the stage.
All right. Thank you so much. So, it really does make a difference to be in person, right? We saw that through pandemic when we were all just sort of confined to our homes and doing everything via Zoom, and everyone had that Zoom fatigue. And it's been really sort of interesting to see that, in fact, there's a flood of interest in just getting back to live in-person attendance. So this conference is really no exception. In my opinion, it is like no other conference that you'll go to. Once you've attended in person, you'll see that it feels very different. And there's just so much warmth. And I think a lot of the videos and commercials for AWIR, if you will, that you've been seeing throughout really convey that warmth. So you get to meet, you're going to meet other colleagues, mingle, you'll be introduced to new people. So you're growing your own network, but also we're expanding that rheumatology community. We know that when we talk to each other, that not only are we enriched, but our profession is as well. In so many ways, there's lots of opportunities to talk about creative ideas and things that you're working on with others. It's also an opportunity at this particular meeting to do the hands-on workshops. So you don't get to do that workshop if you're virtual. So if you're there in person, you will get that opportunity to be there and engage in some of these workshops that we're doing this year. There are also the very popular networking sessions, the sip and share, our dinners, a little dancing and fun. Everyone loves that. You get to earn your CME and MOC credits there as well. And share your needs and interests with us one-on-one. We're all there. The board is always there at these events. So, and I can tell you in the last several years, some of the feedback face-to-face, having conversations has really sort of shaped some of the ways that we've modified or changed or addressed some of these other offerings that we have. And of course, it's an opportunity for you to show your support of AWIR and our mission. And like I said before, it is lots of fun. I would dare to say there's not a more fun conference that's out there. So make sure you're there, bring your families. I'm from Florida, so of course I'm going to shout out to Florida being a great place for your families. The Gaylord is beautiful, and they're going to have lots of things to do as well. So make sure you're there. You have that chance to register, save that date, and start making some plans for the summer. All right. So with that, we're going to start with some of our demographic Q&A polling questions. So if you all, and I'm going to do that as well, go to your Chime app, whether it's on your phone or on your browser. And if you go to the live polling section, you're going to see this question pop up. It's on your screen, but it will also be there on your live polling section of your app. So where do you primarily deliver care? Is it A, in the private practice community clinic, B, in public or government supported clinic, C, in an academic institution, or D, other? I'll give everyone just a few seconds to do that. And I'm submitting my own answer as well. And all right, I can give it a few more minutes. Looks like the majority are in the private practice community clinic. And all right, so we'll move on to the next question. All right, so which of the following best describes your race or ethnicity? So select all that apply. A, Black African, African American, Afro-Caribbean. B, Hispanic Latinx. C, Asian Pacific Islander. D, Native American, Alaska Native, Indigenous, First Nation. E, white. F, other. So take a few minutes and enter your answers. All right. I'll give it just a few seconds because I always see that little things move. See, they're moving right now. All right, so let's move on to the next question. Okay, among your rheumatology patients, which racial ethnic minority group has the greatest representation? And select all that apply, although your greatest will probably be one unless you're neck and neck with another population. So A, Black, African, African American, Afro-Caribbean. B, Hispanic Latinx. C, Asian or Pacific Islander. D, Native American, Alaska Native, Indigenous, First Nation. E, other. All right, few seconds. Seeing that monitor moving. All right, so we've got a pretty good mix of representation of our patients in the different groups. Okay, all right, moving on. Our next session is a CME session, and it's covering what's new in vasculitis and looking at the evolving guidelines and treatment approaches. And we all know that there's been quite a lot going on in this space, both in terms of diagnostically as well as how some of the treatment paradigms have changed. I'm very excited for our speakers here today. Dr. Rhee and Dr. Puja Mehta are here to engage us in this discussion and provide us with some education. So I'm going to need to move on to the next slide. There we go. All right. So our first speaker is Dr. Rhee. She's an assistant professor of medicine in the Division of Rheumatology at the University of Pennsylvania and a member of the Penn Vasculitis Center. She's the principal investigator of multiple NIH foundational and institutional research awards. Her research interests include clinical and translational research in vasculitis with a focus on understanding the role of upper airway microbiome and immunity in vasculitis, as well as the use of high resolution cranial and orbital MRI in giant cell arteritis. She's also a member of the ACR Vasculitis Guidelines Committee, which published the first national guidelines for the management of several forms of vasculitis. She is the co-chair of the ACR ANCA Associated Vasculitis Abstract Category and a member of the ACR Classification Criteria Subcommittee. Dr. Puja Mehta is a rheumatology senior specialist registrar and is undertaking a basic science PhD in post-COVID-19 ILD at the University College London, or UCL, Respiratory Division. She's a strong proponent of cross-specialty working. She has a wide clinical practice that includes ILD clinics and ILD radiology and multidisciplinary teams. And her main research interests are rheumatic-associated ILD and immunotherapeutics. She has experience in drug development and the industry-academic interface and has designed a clinical trial in RA during a pharmaceutical industry fellowship. She also has a background in academic hematology. She's a member of the COVID-19 European Alliance of Associations for Rheumatology, or EULAR task force, and she's currently clinical chair of the Early Career Research Network Committee and member of the Athena Swan Committee at UCL. She supervises another educator after my own heart, as this team seems to be. She supervises and teaches MSc and medical students at UCL and Imperial College London. So she is coming to us virtually from across the pond. So she's coming a long way, so to speak, to be with us here today. So I thank both of our speakers for being here with us today. All right, I'm going to talk a little bit about the CME before I hand it over to our speakers. Here are the faculty disclosures, because this is a CME program. And we are getting the CME accreditation through AKH. So it's the policy of AKH to ensure independence, balance, objectivity, scientific rigor, and integrity in CE activities. The authors will disclose any significant relationships, as we've done in the previous slide. They will have certain rules to follow as far as completing the CME requirements, including these disclosures that are listed here. And please do read the disclaimer as well. And if you want to opt out from AKH Communications, you've got that email there to opt out if you sign up for the CME and you don't want the follow-up. The CE credit, as I mentioned, is provided by Advancing Knowledge in Healthcare, or AKH, and this has been planned, this activity, and implemented by them. In advancing knowledge in healthcare with the Association of Women in Rheumatology. Advancing knowledge in healthcare, or AKH, is jointly accredited by ACCME, ACPE, and ANCC. And you can see that for physicians, it is a 1.5 AMA PRA Category 1 credit that you'll receive for completing the CME. You have to complete those pre-test questions. So hopefully everyone has done that, or if you haven't, do it now. You'll see that on the CME app where you can do the pre-test. And then at the end of the program, please do complete the post-test. And as I mentioned earlier, please, please, please submit questions. I'm excited about moderating and fielding questions to these amazing speakers. There's a great opportunity to ask questions. I know clinically there's lots of issues that come up, so make sure that you're getting a chance to put your questions in. So what are the learning objectives? One is to apply evidence-based practice for diagnosis, assessment, treatment, management of GCA, PMR, and ANCA ANCA-associated vasculitis. The second is to evaluate existing, new, and emerging treatment options for these disease states based on mechanism of action and key clinical trial data. And then to incorporate guidelines, data, and patient factors to personalize treatment and management decisions for patients with these conditions, GCA, PMR, and ANCA-associated vasculitis. Again, as I mentioned before, do your pre and post-test surveys. And when you're done, on the left side of the app, you see the Claim CME section. Please click on that. Follow those directions. The link does expire in 1 month, so don't wait a month to do it. Just try to do it in the next day or two, or just when you're done today, so that you get your credit. And with that, I'm going to hand it over to our amazing speakers and let them take over this important topic.
All right. Thank you so much for inviting me to talk today about vasculitis. This is a clinical and research interest of mine. And I was tasked not to speak not just one and not just two, but 3 different diseases. So I really wanted to focus this conversation on a few key areas that I think will be high yield for you in your clinical practice. I did want to remind you again that the American College of Rheumatology and Vasculitis Foundation did come out with some management guidelines that were published in 2021. A lot of what we're going to be covering today are more recent advances that were not covered in those guidelines, as well as a few common diagnostic issues that can come up. So with that, I will proceed. And we're going to start off with giant cell arteritis. And so with giant cell arteritis, I have found that just the diagnosis of this is very challenging. I led and created our giant cell arteritis fast track program at Penn. So in that role, I've kind of become the go-to giant cell arteritis person for many within our division, as well as within other departments. And I wanted to bring up a couple of common key issues that may be helpful to you as you encounter these challenging cases. I've also had the nice advantage, we don't use ultrasound at our institution, but we do use advanced MR imaging, which has been an area that I've been researching as well. And that's been really helpful and really helping us to understand what is GCA and also what's not GCA. But I won't be talking too much about vascular imaging just because I know that that may not be available to most people in clinical practice. The other thing I did want to mention is I've got several polling questions. I find that this is a really nice way to have active participation and can really reinforce some key learning objectives. So I really encourage all of you to participate in that. It's also just helpful feedback to me to kind of know where you are all at. So we're going to do this in a case-based format, and we're going to start with this first case. This is a common kind of clinical scenario that we come across, and this is a 58-year-old woman. She has 1 week of intermittent severe left temporal headache. She does have a history of prior migraines, but reports this headache is very different. She reports scalp tenderness and photosensitivity associated with the headache. The sedimentation rate is elevated. The C-reactive protein is normal. Her primary started her on prednisone, which led to significant improvement. So this brings us to our first polling question. True or false, improvement in headaches with prednisone distinguishes GCA-related headaches from other headache syndromes? A, is that true, or B, is it false? Okay. And so correct, so a majority of patients answered false, and this is absolutely, that is the correct answer. There are many different headache syndromes that respond to prednisone. And in fact, in the management of migraines, prednisone is a therapy that is commonly used by neurologists just to treat migraines. It's not a common one, but they do resort to use of prednisone. So that's important to just be cautious of, putting a pin on their response to prednisone. I have found that migraines are one of the most common mimics of giant cell arteritis. The other one is trigeminal neuralgia. They have so many similar overlapping features, it can be very challenging to distinguish these two conditions. They both can develop very severe temporal headaches and scalp sensitivity. They're both associated with visual disturbance, and they both improve with prednisone. So it's always important, it's just my common practice is to always screen for other migrainous features that are not typically associated with giant cell arteritis. These things include photo or photosensitivity, nausea and vomiting, which we don't typically see with GCA, but are very commonly associated with migraines. The visual aura that we see with migraines have a different characteristics than what we see in giant cell arteritis. Migraines have a shimmering quality. They can see geometric shapes, kaleidoscopes, zigzagging lines, and they can often be associated with paresthesias like tingling, numbness, pins and needles. So you know, a common thing I hear is, I've had migraines before, this is different. And even though it's different, they can still have giant cell arteritis. It's still a possibility, but it immediately becomes a bit of a red flag. And I think doing a really thorough history can really be helpful in these situations. And so the other situation that we'll talk about with the next case is the patient's acute phase reactants, which also were a little more atypical for what we see with giant cell arteritis. It's also important to remember that migraines are very, very common. You know, depending on the underlying population, it can be as common as 1 in 7 patients. Temporal mandibular joint disorders, which also can be the other mimic for jaw claudication that we see in GCA, are also very common. And just to give some kind of frame of reference, the incidence of being struck by lightning in your lifetime is shockingly as high as 1 in 3,000. I found that statistic somewhere. I was very disturbed. And you know, just, this is not a poll question, but you can think to yourself, which of these, where does giant cell arteritis lie in this spectrum? Is it A, as common as migraines, B, somewhere in the middle, or C, less common than being struck by lightning? And you know, as you would expect, it is less common to get giant cell arteritis than any of these other possibilities. And this is just even when we're looking at adults over the age of 50. So if you take in the whole entire population, it's even a lower incidence. So giant cell arteritis is very, very rare. So it's just helpful to screen for more common things as we're considering this. So moving on, our next case is a 68-year-old woman who's had a year of headaches and which have worsened significantly over the past 4 weeks. They're located in the bitemporal area, and she has no other associated symptoms. What was really concerning was that the initial referring provider checked a sedimentation rate, which was through the roof. It was over 100. It was just beyond the limit of detection. Whereas the CRP was only mildly elevated at 1.1, with normal being less than 0.8. As in this case, as in many cases of headache syndromes, she got better with prednisone. She did undergo bilateral temporal artery biopsies, which were negative. So this leads us to our next poll question. Which of the following laboratory tests would you order to investigate the elevated sedimentation rate? Would it be A, blood cultures, B, SPEP, C, fibrinogen, or D, high sensitivity CRP? And the majority answered SPEP, which is the correct answer. Certainly, infections like blood cultures can also cause an elevated sedimentation rate, but in someone who has otherwise no other clinical symptoms or concerns of sepsis, that would be probably lower yield. Fibrinogen actually can reduce the sedimentation rate, and high sensitivity CRP is really the same as the others, normal CRP. It's just a different set of units, so it's not going to provide you any additional information. This is a reminder that you are probably all aware of, that there's many factors that can influence the sedimentation rate. Many of these things become more prevalent in older adults, such as anemia and renal disease. And a big one are monoclonal immunoglobulins, because of the way the effects these have on the sedimentation process of the red blood cells. It leads to this kind of falsely elevated sedimentation rate. And this is actually even incorporated in the British Society of Rheumatology guidelines to check an SPEP in patients who have discordant sedimentation rates and C-reactive proteins. The prevalence of monoclonal gammopathy of undetermined significance is relatively very high in adults over the age of 50, and can range anywhere from about 2 to 8% of people. So quite a lot of people who have this. And this is a common scenario that I've come across. You know, normally we don't check sed rate CRPs, but someone all of a sudden has a new headache, so somebody checks it, and it's the very abnormal value raises a lot of alarm bells. But when you see that discordance with the CRP, it raises some kind of, again, a red flag, a concern. And if it's a very low probability case of giant cell arteritis, checking an SPEP can be useful and may provide some reassurance as to why their sedimentation rate is so high, and just for future, why it should not be used for any type of monitoring or disease assessment because it's being influenced by another comorbidity. There have been several studies about acute phase reactants in giant cell arteritis. And I'll just say my general feeling about this is that a normal pre-steroid CRP is a very low probability for cranial GCA. That's not to say it can't happen. There definitely are cases I've seen of biopsy-confirmed giant cell arteritis who've had normal CRP and sedimentation rates, but that is the exception, not the rule. And I just wanted to show this table from a paper in which they looked at the concordance of sedimentation rate and CRP among patients diagnosed with giant cell arteritis. And only 0.02% of those who were diagnosed with GCA had a normal CRP. And that's kind of my experience too, is that I find the normal CRP is exceedingly rare in patients ultimately diagnosed with giant cell arteritis. And in our program, we actually a few years ago did a retrospective analysis of the non-GCA cases, made sure that they didn't go on to develop GCA in the future after they tapered off steroids, and about 40% of those patients had normal CRP. So it's become a very useful initial indicator to help me move the probability to a lower side. Other studies have said the sensitivity of CRP is 86 to 87%, which is a bit lower. And of course, there could be a lot of variation in terms of the timing of when the CRP was checked, the underlying population, certainly in patients with large vessel giant cell arteritis with aortic involvement, perhaps the CRP is more likely to be normal. So always make sure to check a sed rate and a CRP. And when you see a normal CRP prior to prednisone, just kind of makes you take pause about whether this could be GCA. Moving on to our third case. Here is another common situation that we come across. In this situation, we have a patient who has established giant cell arteritis. This patient was diagnosed a year ago and he returns for a routine follow-up. He's tapered off prednisone and is doing very well. And the labs show a new increase in the sedimentation rate and an increase in the CRP. But otherwise, there's no other symptoms concerning for active giant cell arteritis, no recent infections, no other new issues. So it brings us to a polling question. What would be the next best step in this situation? Would it be to A, continue to monitor closely, B, restart low-dose prednisone, or C, start tocilizumab, or D, send an infectious workup? Okay, great. All of you are Perfectly on target, 100% said we monitor closely. And there's some changes to that, but that's okay. So just a reminder that sedimentation rate, C-reactive protein, again, are influenced by many other things and can often not be 100% reliable and accurate in determining disease activity in giant cell arteritis. As a result, both the American College of Rheumatology and the AWIR guidelines do not recommend escalating therapy in cases of asymptomatic increase in sed rate CRP. Of course, that doesn't mean ignore it. It could be an early indicator of their disease about to flare, and it certainly would want to be very vigilant and closely monitoring these patients. The minute they develop some symptom or new issue concerning for active disease, you would raise the threshold. It would increase their chances of needing to escalate therapy. But asymptomatic increases alone really shouldn't warrant any changes in therapy as a general rule. Of course, there's always exceptions. And I've certainly seen this a lot as well, where I've seen patients, sed rates or CRPs go up. Everyone gets nervous. We hold steady. We don't change. We repeat it. And over time it gets better, or they just continue to feel well. And so just a word of caution about making sure not to overtreat these patients. So going back to this patient, you decide to continue monitoring him closely with monthly labs and follow-up. You mentioned he does mention he's got slight worsening in slight worsening in his blurry vision in both eyes, which he attributes to his known cataracts. He's being followed with ophthalmology. And so you take this opportunity to again counsel him on the types of visual symptoms that are associated with GCA and which should prompt immediate evaluation. So this brings us to our next polling question. Which of the following visual symptoms is not associated with giant cell arteritis? Is it A, transient vision loss, B, blurry vision in one eye, C, flashes of light, or D, diplopia or double vision? So we'll see what the answers lead to, and it looks like most people answered C, flashes of light, and that is the correct answer. Flashes of light, again, are very unusual for giant cell arteritis. It does make me think more ocular migraines when I hear that. Either way, they need to see an ophthalmologist to assess further. But it's just helpful for patients because of this older population. They all get some type of visual disturbance. And so helping them to understand what are the really critical ones that they should be monitoring for. And honestly, I just tell them, you pop 60 of prednisone on your way to the ER, try to give me a call, but like you're just heading straight to the ER if you develop one of these concerning symptoms of giant cell arteritis, because we do know that the possibility of complete irreversible blindness in the next few hours to days is very real. So this is a time to review the ophthalmic manifestations of giant cell arteritis. This is an illustration of an eye, of an ocular globe with the optic nerve behind it and the orbital vasculature. So giant cell arteritis is a vasculitis. It affects the ophthalmic artery and its branches, which is what results in ischemic optic neuropathy. And the most common manifestation that we see is anterior ischemic optic neuropathy, where the optic nerve head, which is where the optic nerve inserts into the ocular globe, as well as the choroid along the retina, becomes ischemic and can result in very severe, very acute vision loss. This is the most common ophthalmic manifestation. Anywhere from like 80 to 90% of those with ophthalmic manifestations of GCA will present with anterior ischemic optic neuropathy. Oftentimes it's transient, so that's the amaurosis, and it often can start in one eye and then progress to the next eye if not treated. That initial flicker The lights turning off, the shade over the eye, the darkening over the eye, that is an alarm. And even if it goes away after a few minutes, they need to go straight to the emergency room. The worst case scenario is we give them 1 or 2 extra days of steroids, have them see ophthalmology, make sure it's not GCA, but we don't want these patients to go blind. So that is a true emergency in rheumatology, and just helpful to tell patients. And again, it can also present with some blurriness. So if they have transient blurriness in one eye, lasting a few minutes, going away, that also could be an initial sign of the giant cell arteritis. So a darkening, a shade, blurriness in one eye. And the blurriness, you can distinguish from things like dry eyes, because, simple blinking or using eye drops isn't going to necessarily make that any better. The other less common manifestations of giant cell arteritis include retinal artery occlusion. This can lead to very severe central vision loss, where the periphery of their vision is more preserved. Both of these conditions, anterior ischemic optic neuropathy, retinal artery occlusion, the ophthalmologist can see characteristic findings on the fundoscopic exam. So having them see ophthalmology urgently is also very important in helping to identify this. There are very rare cases, 5% or less, of patients who have posterior ischemic optic neuropathy. This can be a little more challenging to diagnose because their fundoscopic exam will be normal, at least initially, but there will be other findings on their ophthalmic exam that can help identify this. Other unusual but symptoms that we can see with GCA are diplopia or double vision. This is double vision in both eyes. So if they cover up one eye, the diplopia will go away. So you need both eyes in order to see the diplopia, and this could be due to ischemia of the cranial nerve or extraocular muscles. Very, very rare cause of visual disturbance in GCA is cortical vision loss. This results from posterior strokes. And so stroke is very uncommon in GCA, but can occur. And when it does, it tends to be in the posterior circulation, with the vertebral arteries and their branches being affected. So that was a brief summary of the ocular manifestations in GCA. And now we're going to move on to talk more about further diagnostic management. This is a case of a 72-year-old man who has new right-sided temporal headache and jaw claudication for several weeks. He's got an elevated sedimentation rate, C-reactive protein. His primary started him on prednisone, 60 milligrams daily 2 weeks ago, and now you're seeing him after 2 weeks of prednisone. True or false, temporal artery biopsy preferably should be performed within 2 weeks of glucocorticoid initiation to optimize diagnostic yield. Is this A, true, or B, false? Okay, and so majority of people say true. And yes, that is the correct answer, true. The guidelines, the ACR guidelines, based on the existing literature, recommend obtaining a biopsy, preferably within 2 weeks of initiating prednisone. We've kind of missed that mark with this patient. He's already been on 2 weeks. Now you have to decide, is it worth sending him to surgery for a biopsy? I would still say yes. I think biopsy still can be informative. And so, even beyond 2 weeks, your suspicion is pretty high. I still think it's worthwhile obtaining, because studies have shown it can be persistently positive weeks, even sometimes months later. And you just need to be aware of the diminishing sensitivity that occurs the longer that they're on prednisone. But we all know that temporal artery biopsies have really poor sensitivity. A lot of times they can be negative. And so why do they go wrong? Well, there are a couple of reasons. The first is we just don't get enough artery. And, it's well established that in giant cell arteritis, they can have skip lesions. And because the inflammatory infiltrates skip around in the artery, if you just happen to sample the wrong part of the artery, you're going to miss it. So we advise to get a fairly long length of artery to be able to evaluate histologically. The ACR guidelines say at least 1 centimeter. I'm going to say try to go for 2 or more. The more that we can get, the higher the diagnostic yield. The other thing is to make sure that the histological workup processing is adequate, and there are established guidelines within the pathology literature about this. They need to get multiple sections. Again, you're sampling multiple parts of the artery to make sure that you're not missing any areas and not accidentally just getting a skip area, a skip lesion. Most pathologists are aware of this, but always important to make sure if there's a common pathology department that you work with to make sure they're using the appropriate protocols for this. The longer you're on prednisone, as we said, the lower the sensitivity because that inflammatory infiltrate can resolve. So trying to get this quickly within 2 weeks, preferably of prednisone. And there are occasions where just the temporal arteries just aren't involved. In our studies using MRI, we have seen around 1 in 10 patients who have no temporal artery involvement, but have occipital artery involvement. And so just to remember that GCA is a clinical diagnosis. And so if your suspicion is strong enough, despite a negative biopsy, you may still want to treat. So going back to our case, you get sent for temporal artery biopsy, and here's what is found. And this is another kind of confusing situation with temporal artery biopsies. In this case, this patient had periadventitial small vessel vasculitis and adventitial vasovasorum vasculitis. So what does that mean? So the normal finding we see, and I guess you guys can't see my arrow, but you can see there's that big circular structure on that slide towards the right. And you see there's these 3, you see the artery lumen and then 3 layers of the arterial wall that are all nicely preserved without intense destructive inflammatory infiltrate invading all the walls. And so what we expect to see in, real classic GCA is transmural inflammatory infiltrate with disruption of the internal elastic lamina. And sometimes we'll see giant cells, but not always. But there are these situations where we don't see that full, robust inflammatory infiltrate. We'll see just this little bit of inflammatory infiltrate in the small vessels and the outer layer of the wall or around the artery. And a lot of studies have now shown that this is something that can be seen in giant cell arteritis. And so it's certainly, I wouldn't call this a negative biopsy. I would still be concerned about GCA. However, there are other things that can present with this. Infections, for example, varicella zoster can present with this. Malignancies, I've seen a case of CLL where they have this. So if your clinical suspicion is still not very strong, you may need to do additional workup for these other etiologies. So these equivocal findings on temporal artery biopsy still leave you a little stumped, and you decide you want to get additional vascular imaging. And this is just a reminder that GCA is not just in the head. It is known to affect other arteries, primarily the aorta and its primary branches. And somewhere as high as 1 in 3 patients are known with GCA can have large artery or aortic involvement. It's most commonly the ascending aorta. So a lot of cases I've seen are just isolated ascending aortic aneurysms. It can also involve carotid, subclavian, and axillary arteries. One helpful note is that those with large vessel disease are less likely to have visual complications. So just help to keep that in mind. But because of this, it is recommended by all of the societies to do large vessel screening in patients with suspected GCA. And this is mainly done through cross-sectional imaging, CT or MR angiogram. This is preferred over just an interventional catheter-based angiogram, which is more invasive And these cross-sectional imaging modalities like CT-MR are able to look for things like wall thickening, which is a little more specific for vasculitis. And so here's just some example images. On the left, you see that ascending aortic aneurysm. Certainly, transthyreoarteritis is a less common cause of this. This is more commonly seen in people with kind of uncontrolled hypertension, atherosclerosis, but certainly it can be seen in GCA as well. Subclavian artery narrowing is demonstrated in the middle image. Here you have a coronal view of a patient, and you see the arrow pointing at subclavian artery stenosis. And all the way to the right is an example of just the wall thickening that can be seen on imaging as well. More and more data is coming out about PET-CT. PET-CT is really helpful to distinguish active inflammation from just chronic damage when we're evaluating these patients with large vessel vasculitis. This is an example from a paper in which a patient underwent a PET-CT. The patient was in clinical remission, and on the left, you see that the PET-CT was just lighting up throughout the aorta and multiple vessels. And a month later, that patient went on to have a true clinical relapse, was started on treatment, and they repeated the PET-CT, and it improved after treatment. So PET-CT could be a bit more dynamic compared to the CT-MR angios. I like to use it in situations where I'm not really sure if some of the arterial changes are related to active inflammation or a result of damage or atherosclerosis or just longstanding, disease. It can be challenging to get this approved by insurance, but we've been able to get it several times in patients, so this can be useful as well. So going back to our patient with the equivocal temporal artery biopsy, now you get a CT angio that shows diffuse circumferential wall thickening of the ascending aorta arch, descending thoracic aorta, wall thickening stenoses in the subclavian arteries. And now you feel more confident this is definitely transthyreoarteritis, and you decide to initiate tocilizumab. However, the patient develops worsening transaminitis due to tocilizumab. You stop therapy, it gets better, you restart it, it gets worse. So this leads to our next poll question: what would you do next for this case? And I will say that I wouldn't say there's like a right answer. I think there's multiple different ways of approaching this, but I'm curious to see what all of you guys think. So A, do we switch tocilizumab from sub-Q to intravenous? B, switch tocilizumab to methotrexate? C, switch tocilizumab to abatacept? Or D, stop tocilizumab and continue prednisone 20 milligrams daily indefinitely? So I'm sensing a lot of uncertainty, either that or the poll's not working. Okay, there we go. All right, so it seems that perhaps half the group thinks we should switch to abatacept, and a quarter maybe think about switching from sub-Q to IV. So again, I don't know what the right answer would be, but I think what I ended up doing was actually C, switching to abatacept. There really isn't any data to suggest that going from sub-Q to IV will diminish any type of the laboratory abnormalities we see with tocilizumab, at least transaminitis. And methotrexate, of course, you still worry about transaminitis, although it doesn't necessarily mean it will occur, so that would also be reasonable. But I opted to do abatacept. And this is based on a phase 2 open label trial of abatacept in GCA. In this trial, they took 41 new or relapsing cases of GCA. They all received abatacept infusions weeks 0, 2, 4, and 8, and then were randomized to get monthly abatacept and placebo. And when they looked at relapse-free survival, as well as median duration of remission, we saw that the abatacept group had significantly better outcomes compared to the placebo arm. So this has led to a phase 3 trial of abatacept, which is currently ongoing as well. I will say just my own anecdotal experience is that in these situations where patients are not able to tolerate tocilizumab or have some contraindication, they've got a history of diverticulitis, for example, and you're worried about valve perforation, I will use abatacept, and I've seen quite a few patients respond well to this. And this has now also been incorporated and mentioned in the ACR guidelines that were published. So not as great data compared to tocilizumab, but certainly another alternative in addition to methotrexate. Here is a summary of several clinical trials that have been done in giant cell arteritis, and I've grouped them into quote unquote positive trials, which met their primary endpoint, versus negative trials, which did not. And methotrexate, there were 3 trials actually, 1 that was positive, 2 that were negative. A meta-analysis demonstrated that there probably could be some steroid-sparing benefit in methotrexate, so that is still commonly used in GCA. Several trials of TNF inhibitors, infliximab, adalimumab, etanercept, all have been negative. We don't recommend using TNF inhibitors for GCA. And then the only drug that's been FDA approved has been tocilizumab. That was based on the GIACTA trial, but there has been other trials of tocilizumab that have been positive as well. We talked about the abatacept trial. There have been a few other drugs that have been studied in phase 2 studies. And now there's a whole list of many trials that are ongoing in giant cell arteritis. So I think really this is evolving and changing, and I'm hoping in a few years we're going to have many more options for these patients. So in this case, the patient was switched to abatacept and did well, tapered off prednisone without disease recurrence. So to wrap up giant cell arteritis, I'd say the main take-home points are that normal pre-steroid CRP or other symptoms associated with more common headache syndromes like migraines, trigeminal neuralgia is another one, TMJ, should suggest an alternative non-GCA diagnosis. I call it the rule of twos, temporal artery biopsy within 2 weeks of prednisone and 2 centimeters in length. I always directly reach out to our vascular surgeons and request a specific length. Screening for large vessel GCA is also important through cross-sectional imaging. And other than prednisone, tocilizumab has the most data demonstrating efficacy for treatment of GCA, but other options also include abatacept and methotrexate, with I'm sure many more to come in the future. So I'm going to move on now to polymyalgia rheumatica. This discussion will be a bit shorter, but I did want to talk about an important trial that has led to a new FDA drug approval for polymyalgia rheumatica. So this case, to set us up, this is a 78-year-old woman who was diagnosed with polymyalgia rheumatica a year ago by her primary. She's meeting you for the first time. You go through back the history, and she says she had very sudden onset pain and stiffness, first in the neck, then in progressing to the right, then the left shoulder. She also developed swelling and stiffness in her MCPs and PIPs, has had muscle pain and stiffness lasting hours in the morning that improved with activity. She did have elevated sed-rate CRP and a normal rheumatoid factor CCP. And she received prednisone and noticed within a day she had significant relief in her symptoms. And despite multiple attempts, she has tried to taper below 8 milligrams a day, but has not been successful. And now our primary is sending her to you to discuss some steroid-sparing alternatives. So this is just a reminder of some of the features of polymyalgia rheumatica. And also just to remind you that about half of patients with GCA have polymyalgia rheumatica, and about 10% of those with PMR go on to develop GCA. So these are 2 conditions that are very closely related. And PMR, some of the kind of unique symptoms are very abrupt onset. Not always, but sometimes these patients, they just wake up. All of a sudden they have severe stiffness, no precipitating events prior. That could be seen with PMR. It most commonly affects the shoulders, followed by the neck and the hip girdle area. They can get distal joint involvement, which can mimic rheumatoid arthritis. So that could be part of their PMR. And that extreme morning stiffness over 45 minutes is also a key feature that can often help distinguish PMR-related aches from other degenerative or non-inflammatory musculoskeletal conditions. These patients have a very unique response to glucocorticoids. It's very quick, sometimes within the same day, if not within several days, they have a dramatic response to 15 milligrams of prednisone. PMR as well also is more often associated with an elevated CRP over an elevated sedimentation rate. And it's also important to make sure you rule out other inflammatory arthritis, such as rheumatoid arthritis or other causes. So this brings us to another poll question, and this will just set us up for a clinical trial that we're going to talk about. Which of the following is true? And so we're going to be talking about sarilumab, as you can gather. Sarilumab is the second biologic therapy that's FDA approved for PMR, the tocilizumab being the first. In the trial of sarilumab, the SAPPHIRE trial, only patients with PMR flare while on prednisone of doses above 7.5 milligrams a day were eligible. Sarilumab was associated with more serious adverse events compared to placebo. Or D, in the SAPPHIRE arm, cumulative glucocorticoid dose at 52 weeks was not different between groups. Give you a minute to think about this. And majority answered B, which is the correct answer. This was a trial primarily of refractory PMR. It is actually the first trial to, the first drug to be FDA approved for the treatment of PMR. And we'll go through some of the other answers in a little bit. Here's another summary of some of the trials that have been done in PMR, very similar to what we saw with GCA. Methotrexate, tocilizumab is shown to be effective in at least 2 trials, and even a trial for rituximab has been performed. But the sarilumab trial that was done, which we're going to go through in greater detail, was led to the first FDA approval. So this was published last fall, and in this trial, they randomized patients with refractory PMR to either receive sarilumab plus a very rapid prednisone taper over 14 weeks versus placebo plus with a more common 52-week prednisone taper. And their primary outcome was sustained remission at week 52, which was significantly higher in the sarilumab arm versus the placebo arm. This was a very strict definition of remission. We're going to go through the different components of it, so hence why such a small percentage of patients actually achieve this outcome. But it was still significantly different. And importantly, the median cumulative glucocorticoid dose was significantly lower in those who received sarilumab. So they used a very strict definition of remission. All patients had to achieve clinical remission by week 12. They could not have any disease flares. They had to maintain normal CRP and adhere to a prednisone taper. 14-week taper in PMR is really fast. I'm not surprised that a lot of patients weren't able to stay off of prednisone. But you can see that there was, despite which part of the definition you looked at, sarilumab seemed to outperform the placebo group. There were many other secondary efficacy endpoints that I just don't have the time to go through. But I think all in all, just pretty much demonstrated that sarilumab was enabled patients to come off of prednisone sooner. No difference in any or serious adverse events. There were more cases of neutropenia that occurred in sarilumab versus placebo, which is expected. We know that the IL-6 blockade can lead to neutropenia. And so going back to our questions, the correct answer again was B. C was wrong because the rates of serious adverse events were similar between the groups, and D was wrong because the cerulumab arm had much lower cumulative glucocorticoid doses than the placebo arm. So this is a great new option for our refractory PMR patients. Certainly have been using this in some select patients who've been having challenges coming off of prednisone. So in summary, cerulumab is an effective therapy. The clinical trial used cerulumab for 1 year, so data on longer-term use is still lacking. And keeping in mind common side effects of cerulumab, neutropenia, arthralgia, diarrhea were some of the most common side effects that were seen in the trial. All right, so I'm finishing up with ANCA-associated vasculitis. This will be a more abbreviated discussion, really focusing on the avacopan, which has been FDA approved now. And I think this is a new drug for everyone, not just within rheumatology, but this is the very first indication for avacopan is ANCA-associated vasculitis. So I wanted to go more in depth about this study. Just to remind you, this is a list of some of the major randomized clinical trials in ANCA-associated vasculitis, certainly not all of them. But I, again, separated these into positive and negative trials and also into induction versus maintenance therapy. Induction being, we're taking patients with active disease, inducing remission. Maintenance is we're taking patients in remission and trying to maintain remission and prevent relapse. There's been a lot of work done over the past few years to help us in our management of patients with ANCA-associated vasculitis. I do also want to highlight the benralizumab trial, which was published in New England Journal last month, which was non-inferior to mepolizumab in EGPA. I won't have time to go through that today, but it was another important study done. And I think the one that I'm going to focus on today is avacopan. And this one is a bit of a unique drug in that it's actually a replacement for prednisone. It was not studied to be a replacement for rituximab, azathioprine, or those other medications. It is a prednisone alternative. And so let's talk a little bit more about complement 5A receptor antagonists in ANCA-associated vasculitis. I'm going to do this in the context of 3 common clinical scenarios. These all represent scenarios in which I've encountered patients come to me asking, hey, I heard about this new drug that was approved by the FDA. Do you think I should start it? And so we'll think about the use of avacopan based on these scenarios. The first scenario, scenario A, is a patient with relapse. This patient has severe features of renal involvement, upper airway involvement, positive ANCA, and is starting on high-dose prednisone as well as rituximab induction therapy. This person has type 2 diabetes as well. Scenario B is a patient with persistent disease. This patient has interstitial lung disease, which has been stable, but the patient's been having difficulty tapering prednisone. Every time he tries to taper his prednisone, he gets recurrence of his respiratory symptoms. And just also a friendly reminder that ANCA-associated vasculitis can also lead to interstitial lung disease as well. So this patient is on 7.5 milligrams of prednisone, having trouble tapering, on rituximab maintenance, also has cirrhosis. And the last scenario is a patient who's in stable remission, who's on rituximab maintenance therapy and nothing else, no prednisone and no comorbidities, and is asking, should I try avacopan instead of rituximab? So avacopan was based initially on studies that were done first in mice and then led to some initial early phase trials in humans, in which they found that blocking the complement 5A pathway, this alternative complement pathway, helped reduce the features or development of ANCA-associated vasculitis. And this is a reminder that ANCA-associated vasculitis is very driven by neutrophils. It's a key pathogenic cell. And that's why the ANCAs themselves are been shown to be pathogenic, because they bind to the neutrophils and it leads to this inappropriate over and excessive activation of neutrophils. And what they found is, as in addition to ANCAs, this complement 5A pathway was also kind of leading to this excessive neutrophil activation, which was causing damage to the blood vessels. So blocking complement 5A would help abrogate this whole process. So a lot of work was done that eventually led to the phase 3 trial of this new therapy. Again, this is the first indication for use of avacopan, which is kind of exciting as a vasculitis person, to have a drug that we're not just repurposing for vasculitis, but was actually developed first in vasculitis. So this is the Advocate trial style study design. They took patients with active GPA, MPA. Many of these had very severe features, including renal involvement. They did exclude those with an EGFR of less than 15 or alveolar hemorrhage. And they all received standard induction therapy with cyclophosphamide or rituximab. Those who received cyclophosphamide got azathioprine. The patients who received rituximab induction did not receive further maintenance therapy. I'm gonna come back to this later, but this was one of the criticisms of this study, that they did not receive any further maintenance therapy. Then patients were randomized to get the study drug, which is a 30 milligram capsules that are taken twice a day. And they rapidly tapered off prednisone within 4 weeks. So really trying to replace prednisone versus getting a placebo and the standard 6-month prednisone tapering regimen. So this is, again, avacopan is in addition to the standard induction maintenance therapies, but replacing prednisone. And the primary endpoints were remission at week 26, as well as sustained remission at week 52, looking at non-inferiority as well as superiority. And so this is pretty exciting, right? We use a lot of prednisone in vasculitis, and patients are always asking, isn't there something else besides prednisone that I can take initially to get my vasculitis under control? Did avacopan actually result in less prednisone use? And the answer is yes. Here you're seeing the mean dose of prednisone over time in weeks in the avacopan group, which is in black, versus prednisone, which was in gray. And the greatest prednisone sparing benefit was really in that first 6 months when the doses of prednisone were quite high. The patients with avacopan were able to get away with much less prednisone. However, it's still notable that it wasn't zero. So patients, again, many patients were still receiving or requiring low doses of prednisone in the avacopan group. And only 12% in the avacopan group were able to come off of prednisone completely, only 12%. However, overall, it was a 1/3, the avacopan group received 1/3 the cumulative prednisone dose compared to the prednisone arm. So still a substantial reduction. And overall, we found first with week 26, avacopan was non-inferior to prednisone, but did not reach the superiority. It did not reach significance for superiority. So they were similar. And then when we look further out, week 52, we found that avacopan both met non-inferiority as well as superiority compared to prednisone. I just want to take, another kind of commentary about this is, again, like 2/3 of these patients received rituximab induction and did not receive any subsequent rituximab maintenance therapy. And so many of these relapses occurred after the month 6 period. So there are some critics who say, well, if they'd gotten that standard therapy of rituximab at month 6, perhaps these differences may have been less. But still, it was at least not worse than prednisone. We looked at the risk of relapse. Again, we're seeing that avacopan had lower risk of relapse compared to prednisone. In terms of glucocorticoid toxicity, which is a major issue in these patients who receive a lot of prednisone, overall, we can see that avacopan was associated with lower glucocorticoid toxicity compared to prednisone when we use the glucocorticoid toxicity index. There's also some hints of better renal recovery in those who got avacopan. Here's a graph showing the change in eGFR over time in the two groups. And you can see there was a couple of a little bit improvement in eGFR in the avacopan group. They've done additional studies looking at this, looking at proteinuria and other measures, kind of consistently demonstrating potential benefit here. Overall, health-related quality of life was also overall better in the avacopan group. And importantly, there were no differences in adverse events. So of course, we worry. You're blocking out neutrophils. We need neutrophils to fight off infections. And we don't see any difference in serious adverse events or serious infections. You know, I look at this infection data too, though, and sometimes when we want something to replace prednisone because of infectious risk, I do kind of quote this data that there wasn't any difference between the two groups in terms of infection risk. However, overall, many other side effects that happened from prednisone were reduced in those who got avacopan. Abnormal liver function testing did occur as well, and so it did lead to several patients withdrawing from the study. All cases did resolve once they discontinued the therapy, but it is important to be monitoring their liver function monthly for the first 6 months when starting this medication. There were some limitations of this study. Again, this is the very first trial that has been done. There's still a lot to learn. Again, a major criticism was that rituximab maintenance therapy was not given. And in addition, this trial the protocol for this trial was created before the PEXA-VASc trial. And in the PEXA-VASc trial, they found we can actually get away with a lot less prednisone in very severe cases of ANCA-associated vasculitis. And so some critics argue if they had used the reduced prednisone dosing regimen from the PEXA-VASc trial, perhaps some of these differences would be less. So still some unanswered questions. There are additional knowledge gaps in terms of long-term safety. What are safety issues in pregnancy, lactation, pediatric population? Can we use avacopan in milder disease for long-term disease control or maintenance therapy? We don't know the answer to that. What is the optimal duration of avacopan? The trial was 1 year. Is there benefit to continuing it further or not? What's the best glucocorticoid dosing regimen to use? And of course, a big issue is cost effectiveness. It's a very expensive therapy, and so that can be important as well. So going back to our 3 scenarios, this is not a poll question, but you can just think to yourself, which of these patients, based on the Advocate trial, would you consider avacopan, or do we have good evidence for use of avacopan? And, patient A was that relapsing patient, high dose prednisone, B was persistent disease, moderate dose, and C was someone stable remission on rituximab maintenance. And really the trial shows that patient A would benefit the most. Active disease requiring high doses of prednisone, renal involvement, also type 2 diabetes, so a lot of risks with prednisone. This would be a great candidate for avacopan. Patient B, it's unclear, again, how much prednisone at lower doses, whether avacopan can completely replace prednisone. It's a little bit of a gray, unclear area based on the trial, didn't demonstrate it. This patient also has cirrhosis, so we just got to be more careful. It's a relative contraindication for avacopan. And patient C, rituximab maintenance, avacopan has not been studied to be a replacement for rituximab or azathioprine maintenance. It is meant to be a replacement for prednisone. So patient C, I would not recommend switching over to avacopan. And this is my last slide, just to re-summarize, or just to summarize what we know about avacopan. The mechanism of action is it blocks neutrophil activity by inhibiting complement 5A receptor. The target population was severe ANCA-associated vasculitis, especially if those with kidney involvement may benefit, or those who have a higher risk of prednisone toxicity. It was shown to be non-inferior to conventional prednisone, possibly some additional renal benefits. It's a 30 milligram capsule, gets given twice a day, and you do need to monitor the LFTs monthly for the first 6 months. Also important just to make sure patients don't prematurely stop prednisone. I do follow what the trial did and do like a 4-week rapid taper once they've started the avacopan. I've had a couple cases where they stopped the prednisone a little too soon before we got the avacopan on board, and it led to some disease flare. So to be cautious about that, make sure we counsel our patients. And currently we have data for 1 year, but I think beyond that it's still unclear whether there's any benefit. And I think, and that is where I will stop and hand things over to Dr. Mehta.
Thank you so much. That was incredible, a very amazing overview of all the different vasculitides. And I feel like I'm going to change gears slightly with a different shift in topic. So the title of my section of the talk is Vasculitis in People of Colour. And my main disclosure, if I can move on, is that I'm not an expert in vasculitis, unlike Dr. Rhee, and I'm mainly looking at the lung. So I'm doing a PhD in ILD and also have some subspecialist expertise in hyperinflammation. But the reason that I'm talking to you today is because there's an aspect of vasculitis, and particularly giant cell arteritis, that I thought would be useful for us to discuss, to shine a light on with respect to ethnicity, race, and disparities. So I'm going to kick off with a poll. Does GCA occur in non-white people or people of colour, however you want to refer them to? I can't yet see the results. Ah, there we go. And we're getting some answers through. So the majority of people said yes, and then the second most common answer was yes, but not commonly. So I thought I'd kick off with some cases to help illustrate some points. And this is a patient, a 55-year-old female who's Indian, who had a 2-week history of headache, which was unilateral, on the background of a 4-month history of shoulder girdle pain, worsened by infliximab infusion, anti-TNF for ulcerative colitis, inflammatory bowel disease. Of note, there was no jaw claudication or visual symptoms, and significant past medical history included the ulcerative colitis, for which she was on infliximab, hypertension, and nil else. Her inflammatory markers showed an ESR, a sedimentation rate of 50, and a CRP of 19, both modestly elevated. And on examination, there was bilateral temporal artery tenderness, but nothing else to find. So the questions that were relevant at the time from the patient's daughter is, what is the diagnosis? And the rheumatology attending said giant cell arteritis does not occur in non-white people. And the patient's daughter responded, is that true? What is the evidence? There are important things that the team was considering at the time. Was this a delayed hypersensitivity, given that there was a temporal association with the infliximab infusion? The shoulder girdle pain got worse every time the infusion was given. Is that a thing? Was there a risk of steroid-related adverse events because of her ethnic origin? She already had hypertension, and therefore was there a risk of starting steroids if there was diagnostic ambiguity? And what were the baseline inflammatory markers? How were the bowels? What was the alternative diagnosis? And that's important because she had a pre-existing condition of inflammatory bowel disease. And her baseline ESR was about 40 with a CRP of about 10. And therefore this was not in keeping with her inflammatory bowel disease, and her bowels were completely stable. So there's no obvious alternative diagnosis other than the infliximab issue, and there were no case reports at the time on PubMed that this could be an issue, although obviously drugs are idiosyncratic. So how likely is this patient to have giant cell arteritis? Are we going with low, moderate, or high? Oh, wow, an absolutely even split across the board, which exemplifies the fact that GCA is hard. It's never easy. So what happened next? The patient had a temporal artery biopsy, which was negative. She had a good response to steroids. The headache completely resolved. The shoulder pain also got better. The infliximab continued to have a mild worsening in terms of the symptoms. So when she had her next infusion, the symptoms did get a little bit worse, but nowhere near where it was before. And the impression was of a temporal artery biopsy negative giant cell arteritis. In terms of outcome, longitudinally, steroids were discontinued after 18 months. She had no relapse during that period, but she did develop type 2 diabetes as a result of the steroids, and that has continued for at least 15 years after this incident. So did the patient have giant cell arteritis? What was this temporal association with infliximab? Her inflammatory markers did actually improve back to baseline with the steroids. And should ethnicity influence our assessment in terms of risk-benefit analysis? Because she did develop type 2 diabetes as a result of steroids, and she was South Asian and therefore had an increased risk. And I just want to also give you a disclosure here that the patient's daughter, who questioned the rheumatology attending, I was not a rheumatologist at the time, was me. And this is probably where I became a little bit interested in terms of diagnostic uncertainty and rheumatology in general, which is, I think, as we all know, is more of an art than a science. And the diagnostic challenge is exciting for us, but it also does make it hard, which makes us need to use our critical thinking. So there was another patient that I encountered later as a rheumatology fellow. I was referred this patient from the neurology ward when I was starting my rheumatology fellowship. And I was unable to take a history from the patient. The patient was very sleepy. But looking through the medical notes, he was previously fit and well, 75-year-old male who was Black, no past medical history. He attended the emergency room with a 2-week history of headache. There was muscle ache, but no jaw claudication, no visual symptoms, no fever, nausea, vomiting, rash. The CRP was 50, ESR was 83, the full blood count or the complete blood count CBC was normal, and there were no previous inflammatory markers in order to see what his baseline potentially was from the ESR. The CT head was normal, and that was requested because it was a 2-week history of headache and the diagnosis was not clear. The CRP was a bit high. He was afebrile. Temporal artery examination was unremarkable. There was no bruise. This is what I could examine when he was very sleepy, and the pulses were normal. But he was obtunded, and I think you do use the Glasgow Coma scale in stateside, and his GCS was 12. I was able to take a collateral history, and his son was at his bedside and said he's always groggy after a nap. And although I wasn't really able to rouse him very easily, and the referral from the neurology team thought that this was giant cell arteritis. He was on day 4 of prednisolone 40 milligrams, and they'd asked rheumatology to review with the question of, should we give him intravenous methylprednisolone or 60 milligrams of prednisolone? So the question to us was, how do we escalate the dose? Should it be IV or should it be a higher dose oral? Because they were confident this was giant cell arteritis. So I phoned my attending, and she told me giant cell arteritis can occur in people of colour. People often think that it doesn't. So let's increase the dose to 60 milligrams of prednisolone, get a temporal artery biopsy, and we'll review on Friday in 4 days' time. And this was a real life case, and this often happens, that we don't have access and availability to senior review straight away. And I sat on the ward thinking, how likely is this patient to have giant cell arteritis? Is it low, moderate, or high? Unanimously, we have moderate. So let's see what happened. As I said, I sat on the ward documenting and thinking something doesn't really feel right. So I phoned the attending back, and we requested bloods, including immunoglobulins, protein electrophoresis or serum electrophoresis, HIV test, syphilis, and a lumbar puncture. And remember, this patient was on a neurology ward. So the neurologist, this is their procedure, that, you know, they could throw a lumbar puncture needle from far away from the room and get it in first time. And that's what they did. And this was a diagnosis that was secured. And we found the diagnosis to be a cryptococcal meningitis with a new diagnosis of HIV in this 75-year-old male. His lumbar puncture showed a very high pressure. It was turbid. That was the same day result that we got a serum CRAG or cryptococcal antigen on the blood as well as the CSF, and the HIV test came back the next day. So this was a patient that was referred from the neurologists with a confirmed, in their mind, diagnosis of GCA. And the attending, if you remember, had thought that actually let's not be dissuaded from the popular rhetoric that GCA does not occur in people of color and go with it. And actually it turned out to be a completely different diagnosis, meningitis. The final patient that I wanted to share with you was a primary care referral to ambulatory care for query giant cell arteritis. This was a 61-year-old female who was Black. And ambulatory care in the UK is a setup within the emergency room, but it's manned by medics, not ED, and primary care can refer straight to ambulatory care in order to be seen by a medical team. So it's sort of fast-track service. The patient had diabetes on metformin and had a history of a 1 month of headache, nothing focal, bilateral blurred vision, and constitutional upset, so minor unquantified weight loss and no fever. And her CRP was very high, a CRP of greater than 250. And the medics in ambulatory care requested a septic screen with a chest x-ray and a urine dip, which was negative. Chest x-ray showed nothing focal. And they discharged her home with empirical antibiotics for an outpatient CT chest, abdomen, and pelvis, requesting blood cultures, but not waiting for the results, giving her antibiotics to cover infection and an outpatient CT chest, abdomen, and pelvis. So again, how likely do you think it is that this patient had giant cell arteritis? Okay, so a bit more mixed, and here we have low being the winner, and then moderate, and then high. So low is the most popular option here. So I'll tell you what happened next. 4 days later, she lost vision in one eye and came back to the ED, represented, had an ophthalmology review, which showed an anterior ischemic optic neuritis, likely giant cell arteritis, and she then had appropriate GCA management with intravenous methylprednisolone and tocilizumab. And both her headache and CRP responded beautifully. Her temporal artery biopsy came back positive for consistent features with giant cell arteritis, but unfortunately she was rendered permanently blind in one eye. She had worsening glycemic control. If you recall, she had diabetes already on metformin, and she was then escalated to sitagliptin. So the important point here is that she had a CRP of greater than 250. The likely diagnosis was thought to be infection. She was sent home on empirical antibiotics, and the ED team, or the ambulatory care team, as well as most of the audience, thought that her diagnosis was unlikely, low probability of GCA, and actually she's now permanently blind in one eye, showing that this is never easy. So I wanted to discuss this popular myth of giant cell arteritis not occurring in people of color. And I think Dr. Rhee has beautifully demonstrated that the symptoms in GCA and PMR are non-specific. This is never easy. And although this is our medical emergency that we hope A&E, so the emergency room, as well as acute medics and other general medics will be able to handle, this is hard even for us. So we need to make sure that we are thinking about this properly and getting it right first time. Although we have fast track pathways and imaging, we've heard about CT PETs, ultrasounds, we know about, and magnetic resonance imaging, our cognitive biases can confound who we select for these fast track pathways and how we interpret the results. And there's often a popular rhetoric and teaching that GCA is very rare in ethnic minorities. And over time, this can be shortcutted and translated to GCA only occurs in white people. And this is what I have heard during my training. I'm a trainee right now. This is what I've seen being said in various conferences by experts, key opinion leaders. And this is therefore what is being disseminated pervasively to each other and to other medical specialties. And these myths can have really severe consequences for all of us, but particularly for people of color, because we all know that it is imperative to make a prompt diagnosis and therefore institute early management for GCA, because the complications can be irreversible and life-threatening, not only in terms of visual loss, but also with respect to aortitis and large vessel vasculitis. There is sufficient evidence to refute the dogma. And this is a very busy slide, but I just want to alert you or orientate you to the table on the left. This was our literature review from the comment that we published in the Lancet Rheumatology last year, showing that there is a lot of data, observational cohort studies from all over the world. You have America, Japan, India, China, Singapore, the UK, with decent numbers, although that the majority were retrospective, showing population ethnicities and diagnostic criteria that was secure, many with temporal artery biopsies that were positive. So if I just grey this out and ask you to focus on the right now, we wrote a piece with this literature review in the appendix, which was a multi-center international study, authors from the UK as well as America, John Stone, India, Aman Sharma, David Liu from Australia, trying to endorse this very important principle that we need to remember, that giant cell arteritis can occur in people of color. And there was a seminal study in JAMA in 2019 of 580 odd patients who had a temporal artery biopsy, and the population age and sex standardized incidence rates per 100,000 patients were showing almost near parity between Black and white patients. They had a post hoc analysis that they published in last year, 2023, which further demonstrated that the clinical presentation was similar in both groups, the Black and white group, and there was no significant difference in biopsy classification, active versus healed arteritis, or visual or ophthalmic findings. So this is really important, that in terms of clinical presentation, it's likely to be similar, and biopsy and ophthalmic findings are also similar, and we need to not be dissuaded by ethnicity in either direction, really, and focus on clinical signs. We do know that the data shows that there is a higher incidence, or the highest incidence, of giant cell arteritis in North European populations and Scandinavian populations. But it's important to remember that race is a socio-political construct. It's not a natural biological variable. And although genetics are important and are likely to cluster geographically, skin color should not be used as a surrogate marker to define populations. This is really problematic and subject to a lot of problems. And if we oversimplify, we can lead to premature diagnostic closure and false attribution of the significance of race to biological causative mechanisms. And we know that in clinical practice, in real life, we are all very busy, and we like to rely on pattern recognition, which can sometimes be helpful. The book Thinking Fast and Slow describes two systems of thinking, which are helpful, but it's not everything. So important to challenge ourselves and each other. And remember that defining populations on arbitrary features can promote societal and institutional racism and might drive inequity. There are lots of reasons that the incidence of GCA in people of colour is likely to be underreported. So the data sets that we have, the data that we have, is subject to limitations. And we know that ascertainment bias is likely to prevail. Our vasculitis are predominantly based in affluent, resource-rich, predominantly white areas, therefore geographical variation. And ethnicity data, very interestingly, may be legally prohibited to avoid discrimination in certain countries like Germany and France. We're really not going to get the ethnicity data that we need in order to prevent discrimination. This may actually, unfortunately, reinforce the disparity and the inequity. Minoritized people are usually under-recruited to registries and clinical trials, and there are lots of reasons for this, but we need to examine and dismantle structural, language, and cultural barriers to address the historical mistrust, and we need to be intentional about this. Ethnicity classification, whilst important, particularly for research reasons, is problematic. It's self-reported, and every category, including the white population, is heterogeneous. And there are beautiful data sets out there and commentaries outlining that even the white category is problematic. If we classify Italian, Spanish, Scandinavian patients all in one group, that may be doing that category a disservice and an injustice as well. Unraveling the true contribution of genetics and environmental factors such as seasonality and infection is really difficult, but we do know from the data that we have that GCA incidence follows the population prevalence of the HLA-DRB 104 variant, which is the strongest genetic risk that we know about with respect to giant cell arteritis, which increases latitudinally, so increasing latitudes from the equator. Our ancestry tests that are widely available now, that many of you may have done yourself or had patients requesting, the reliability is unclear, and the clinical relevance is also unclear. So although we have more access to these genetic ancestry tests and they're very interesting, right now we don't really know how to interpret them. Race corrections have come to the fore recently, particularly with COVID and pulse oximeters. And I think we've all heard about this in terms of pulse oximetry being less accurate in people of colour. But what about rheumatology? When we wrote our piece, at the time of writing, we weren't aware of race corrections in giant cell arteritis. But after publication, the next day, somebody sent this to us, a rheumatologist in the UK, saying, "Are you aware of this?" And we said, no. This was a race correction for a risk probability calculator that is called GCAPS, which is published. It's a probability calculator for the risk for giant cell arteritis, which is not validated. But this was an adjustment to that GCAPS score that was being used in NHS clinical trusts in the UK. And here you can see I've ringed the problematic issue where you have an alternative diagnosis as or more likely than GCA has a negative deduction of -3 points, but also being from a non-white ethnic population also results in -3 points. So irrespective of the other features, age, onset, CRP, any other clinical features like PMR and the temporal artery exam, if somebody is not white in this probability risk calculator, they would automatically get -3 points, which is not based on evidence. And I want to hold judgment and reserve judgment myself, but also I would caution all of us to do this, that the authors of this risk probability calculator and the adjustment were probably working from good intentions, and their rationale, which we had a reply to our letter, demonstrated that there was a concern about steroid-associated adverse events in people of colour, and therefore the risk and benefit with respect to giving people of colour steroids needed to be taken into account. So this came from good intentions, and we need to acknowledge that. This is not malicious. This is not a group of people that are trying to do harm. They're actually trying to save people of colour from harm. But is this appropriate? Is it evidence-based? A lot has been written recently about race corrections in medical algorithms, and this is fantastic because we really do need to start thinking differently and challenging our assumptions and our biases. And this was a really beautiful, a very nice comment that was written in the New England Journal of Medicine. And I just wanted to highlight a few of the key findings. There's a very long table with a lot of detail, but I've just picked out a few of them for you, showing that race corrections are occurring in multiple specialties: cardiology with respect to heart failure, nephrology, obstetrics, pulmonology. We've talked about the race corrections with respect to pulse oximetry and spirometry, and also endocrinology. But here I'd probably say this should be /rheumatology, because they're talking about the FRAX osteoporosis score. And the equity concern for all of these algorithms really are that we can have treatment delays, delayed investigation, dissuading offering trials of labor to people of color, misclassifying disease activity and delaying treatment. And the evidence base that these algorithms are based on is tenuous. And yet these are standard practice that is being offered all around the world. And for me, I think the nephrology EGFR race adjustment is probably the most widely used, because we do this all the time. And I've personally never really questioned it. I thought this was accurate. And so just reading and discussing in forums like today is really important, because it's not about blame, shame, or guilt. This is about being open and humble to questioning assumptions and each other and data, because this was based in at once upon a time on data, but there may be flawed assumptions in that data collection that we need to be aware of. And this also applies to rheumatology. I personally think that this is useful to see that nearly every specialty is represented in the equity concerns and race corrections, which makes it actually easier to address, because this is not us and them. It isn't that other specialties are getting it wrong, we're getting it right, or we're getting it wrong and others are getting it right. This is actually all of us, which makes it easier to then tackle, because this is actually all of us. And I think that's something that we need to be mindful of. The authors of this piece have written very beautifully the issues, and I just want to pick out a few key excerpts for you. They state that often no explanation is given, or the race corrections are based on outdated, suspect racial science and biased data. There are enmeshed social and biological pathways, and if adjustments deter clinicians from offering clinical services, they risk baking inequity into our system. And very nicely, I think this key point, the last point that I wanted to highlight from this paper, was that this doesn't mean that we should ignore race. Doing so would blind us to the ways in which race and racism structure into our society. So the knee-jerk pendulum swing to the other side, going, we need to be colorblind and not see race at all, is not appropriate, because if we do not see race, we do not see people and the challenges that they may have faced. So it's not about being blind, it's just about being mindful and open to new perspectives. They outline, or they cite, I should say, a very a nice paper that was published in JAMA, slightly embarrassingly, in 2003, that is relevant for today. It's never too late to learn a lesson, but I think it's really nicely outlines 7 rules for race in medical research. Firstly, we should justify including race and ethnicity. Secondly, describe how subjects were categorized. The third statement is race and ethnicity should not be a proxy for genetic variation. Fourthly, differentiating between race and ethnicity as a risk factor or a risk marker, which is really important when we come to think about algorithms. The 5th point is we should consider other factors like racism. Sixthly, consider socioeconomic class as the biggest source of bias. And lastly, do not use stigmatizing language when we are talking about this or writing about this in our publications or teaching each other. The authors of the New England Journal paper make 3 rules for race correction in clinical algorithms. Firstly, what is the evidence? Is it robust? Have we considered bias and confounders? Secondly, are there plausible causal mechanisms, if we are making any corrections, why do we think that is? Is there a plausible biological mechanism? And lastly, will this relieve or exacerbate health inequities? And I think that 3-point checklist is really important if we come across race corrections, in order to determine whether this is something that we should be blindly pursuing or not. So race corrections in GCA probability algorithms are important to consider as rheumatologists, because we do know that there is a higher risk of steroids adverse events in people of color. However, race corrections have significant consequences. And when I say corrections here, I'm not saying that there needs to be a formal didactic algorithm like we've just seen. It may be a subconscious implicit bias that is so fast that we don't even realize it. We may be doing this all the time, and we won't know until we challenge and question ourselves and each other. So we don't want to exacerbate health inequities, because once these practices are established, they become institutionalized. That can happen really fast, particularly if it's somebody of eminence saying it. And penalizing people of color can lead to missed and delayed diagnoses, which can be life-threatening or sight-threatening, just like we had with that patient, the third case that we saw, who is now permanently blind in one eye. So we really need to move towards race-agnostic algorithms, and prioritization for fast-track pathways should be on clinically relevant variables, the signs, symptoms, labs, over skin color. We really shouldn't have to think about skin color, because it should not be relevant with respect to diagnosis. So my question to you is, are race-based corrections without evidence racist? Yes, no, or maybe. Just waiting for some results. Oh, we've got a bit of a changing a movement, and I think there's just an edge with C, maybe, but very closely followed by, just by a whisker is yes. So either yes or maybe. Now, this question is deliberately provocative, or is it? Is it provocative, and why? I think it's very uncomfortable to use the word racism. Actually, it's uncomfortable for a lot of people to use the word race. And if you take it to 2 steps further with racism, it's very uncomfortable. And I think it's important to take a step back and think about, what do we mean by racism? First of all, there's no statement of intention or malice with racism. And this isn't anyone's fault, because we've all been socialized in society. So it's important, I think, to take a step back and think that this is socialization over individualization. And this may be well-intentioned, but of course, intention is very different from impact. And if there's potential harm, we really need to be extremely careful. The concept of prejudice, discrimination, antagonism towards a marginalized group is really important. And I think that, as I said, this was deliberately provocative because it's uncomfortable. But the more we talk about race, bias, and prejudice, the more comfortable we will be, and the more that we can actually address this. Because if we shy away from it, thinking this is not us, this is them, we will never address it. So I think it's really important that we assuage our own discomfort. Race-based corrections can perpetuate racism and contribute to disparities in healthcare. We can reinforce stereotypes, violate individual autonomy, and perpetuate disparities. And it's really important to remember that a lot of this, there is a lack of scientific basis, and we need to go back to whether this is biologically plausible and do we have evidence. So another poll question to you: should we include race or ethnicity at the beginning of clinical presentations? Yes, no, or maybe. So should we say this is a 52-year-old white male, a 35-year-old Asian female? Yes, no, or maybe. A very even split, but just edged it with no. And genuinely, I don't, oh, actually it's all changing. We now have yes and maybe as the key, as the leading votes. which demonstrates, I think this is a really hard question. And I don't really know what the answer is. There's a very nice paper in the New England Journal of Medicine, again, which outlines the issues for and against. In some cases, this may be really helpful. Do we end up skewing our thinking right from the beginning because we lead with it? Is it as important as age and gender, or sex and gender? Should we put this in the social history rather than right at the beginning? Is it important to just present it, but then also be very intentional in questioning ourselves? I'm not sure, perhaps we can discuss that when we come to the Q&A, but I think this is interesting to discuss because it's so natural. I actually would find it very difficult not to say a 55-year-old white man or a 60-year-old Black woman, because it's just so autopilot, muscle memory. So to change that, I think there'd have to be a really good reason, but I think it'll be interesting to discuss later. Cognitive bias is very common in medical practice. We all have bias, even if there is sufficient evidence. And for me, as I said, this vasculitis is not my pet subject, but I am encountering this, and I think we all are in whatever areas of specialist interest we have. I'm encountering this with respect to methotrexate and the lung, because I can publish on this, I can speak, I can teach, and however many times I teach this, there will still be people who will see the data, see the evidence, and yet still in their hearts and mind be wedded to the fact that methotrexate may exacerbate or cause fibrotic ILD, which it really doesn't. And it's really hard to bust myths. And I think we need to acknowledge that however intellectual, academic, erudite, and trained we may be, that we are all limited and subject to these cognitive biases and myths. So why are myths so hard to bust? Particularly hard if there's racial bias. First of all, eminence-based medicine. We are more likely to retain and believe information if we hear it from somebody that we trust, admire, respect, and someone that is seen to be an authority in an area, rather than reading from a textbook or on PubMed. We know that there is structural bias. Every single one of us has implicit bias, and we will not address them unless we are honest and humble and open in examining our own biases. Confirmation bias is really important. So we might think something, then we see a case, or we hear about something or read it, and then it becomes solidified and concreted in our minds. There is lack of diverse representation and research. And I just want to pause here for a moment, because this is not only at the patient level, which is what I talked about earlier in terms of minoritized patients being represented in registry data or clinical trials. This is also at the researcher level. So for example, lupus disproportionately affects Black women, who are likely to have the worst prognosis. They are woefully underrepresented in clinical trials, Black women, as well as lupus KOLs, key opinion leaders on our podiums, on our stages, publishing in the New England Journal of Medicine, which is where we believe, on panels, on committees, you know, when populating programs. And this actually does trickle down and then end up being cemented in what we believe. Inertia is very common. Humans find change very difficult, including me, and there's inertia at the individual as well as the institutional level. There's got to be very good reason to change, and we need to incentivize people to change. It's very hard to change or if something doesn't benefit you either. So we need to really hit home why structural bias, medical myths are causing harm in order to make changes, and that's hard. So to summarize, I really do think that race has no place currently, with our limited evidence, in GCA diagnosis. And we know that timely recognition and management of GCA is important, and misdiagnosis can be devastating. There is a popular rhetoric that GCA only affects North Europeans, which is not supported by observational data. And we've talked about how the true incidence of GCA in people of colour is likely to be underreported. Race should not influence our clinical decision-making. We should rather focus on what we know: clinical presentation, signs, symptoms, laboratory, imaging tests, and not skin color. But be mindful that our algorithms may be biased because of our own bias, that we may populate or fast-track patients into algorithms, fast-track investigative pathways, or not because of our bias. As rheumatologists, we have a responsibility to avoid reinforcing inequity, and race-agnostic algorithms are important. We need to be data-driven, and evidence-based medicine is heralded as the gold standard. So we hold this up as we are following evidence-based medicine, and we feel very virtuous. However, we need to exercise our critical thinking when interpreting that evidence base, that data, including appraising the biased context in which data is generated. Communication is absolutely critical. We need to avoid racial stereotyping and profiling, which may contribute to worse outcomes, and communicating within ourselves, like opportunities like today within rheumatology, but also cross-specialty when we're talking to neurologists, acute medics, renal physicians and so on, and our patients. And patient information leaflets also need to be updated, because when a patient is diagnosed with giant cell arteritis, goes on a website, finds resources, and only sees white faces or does not see themselves, that is problematic. And we all need to examine our cognitive biases. So I'd like to just stop there. Thank you for your attention. And I hope that there is some substrate for discussion.
Absolutely. Definitely lots of food for thought, if you will. And lots of questions have come through. I just want to say thank you to both of you for really reiterating this idea that we have to still, as physicians, be physicians and deploy critical thinking and consider not only the evidence at hand, but also the bias and the sort of riddled with controversy and ambiguity, whether it's diagnostically, as Dr. Rhee pointed out, with all of the different data and clinical presentations and some of the myth busting that she did with vasculitis, and also just addressing some of our biases. So I thank you both. That was wonderful, and definitely lots of questions. So I'm going to start with a couple of questions that came in really about how long we use avacopan in our vasculitis patients. So for example, this specifically was ANCA positive GPA with kidney involvement, biopsy proven, and then what's the longest duration of avacopan use that you've had to do, Dr. Rhee?
Yeah, happy to answer this. The data is for 1 year. And we don't have data about risks and benefits beyond that 1 year. So my general practice has been to limit it to 1 year. There are providers who even suggest, is 1 year even necessary? Is, the greatest steroid-sparing benefit was in the first 6 months. Is 6 months adequate for that? With people on the other hand saying, well, potentially some additional renal benefits may support using it the full year. So I think that's kind of my thought about it. 1 year at most. Perhaps in some patients, 6 months may be adequate as well.
Okay, and then a couple of questions about diagnostics. So we did talk about how it wasn't always a clear-cut temporal artery involvement. There could be other large vessels that are involved. What about when it is involving some of these other areas? Are there any other potential locations for biopsy, for example, that you've seen? Like, there's a diagnostic conundrum. We absolutely are trying to get biopsy, and let's go to another vascular additional site. Does that ever come up, and what's been your experience with that?
The only area that we tend to biopsy are the temporal arteries, because we know there's a lot of redundancy to the vasculature on the scalp, and so we can remove those arteries without significant consequence. I think, the challenges in a large vessel vasculitis is we don't want people to hemorrhage or have other complications. So we generally don't biopsy other areas. However, if patients are going for surgery anyway for revascularization, for example, they've got a large ascending aortic aneurysm that is at risk of rupturing, and their vascular surgeon is taking them for open repair. Those are cases where we can get pathology, and I commonly see those patients coming to me. They never got a prior diagnosis, but then incidentally on the pathology after their revascularization surgery, they found inflammatory infiltrate suggestive of a vasculitis.
And what about the bilateral versus unilateral temporal artery biopsy?
Yeah, there's, I'll tell you that the guidelines suggest unilateral if patients have localizing symptoms, and most of the data suggests that getting the contralateral side doesn't have a lot of additional value. A lot of people still end up getting bilateral biopsies, and I think part of the thought is that we need enough artery to avoid that skip lesion conundrum or the sampling bias. So if the surgeon doesn't feel like they can get enough of a sample through one side, that may be a reason to go on both sides. My general practice is to do unilateral if they've only got unilateral symptoms. If they have non-localizing symptoms like just a fever, then I may do bilateral.
Excellent. Now, how about switching gears a little bit? How can we collaboratively arrive at global guidelines as to when the consideration of race could be beneficial to racially minoritized patients?
When race could be beneficial?
Mm-hmm. When
So
we consider race clinically, when could that be of benefit? You know, we're now connected globally, right?
Mm-hmm.
So if we are able to get data from different regions, how do we use that data? And is there a role for using that data to say, okay, in these scenarios, it might be useful for us to consider race?
That's such a good question. And I think that we are increasingly connected. I mean, just this very conference today shows that virtually from our own homes, we can communicate and collaborate faster than we've ever been able to before. We have a lot of registry data that are now in their mature stages. The BSR, the British Society for Rheumatology, the Rabbit Registry in Germany, there are lots all over the world. And I think that this is actually something we were discussing at the Global Education Committee for the ACR just a couple of nights ago. I'm one of the international advisors in terms of how to link up data sets and researchers from across the globe in order to use the rich resource of data that we have, pool it together and answer questions with better power. I think that undoubtedly there will be some value in collecting race data. Eventually we will be able to use it in order to endotype and subgroup different diseases, because I think anecdotally we do see some differences in presentation with respect to rheumatoid arthritis, for example. But unless we have, as you say, the wealth of data available to us, we won't be able to draw meaningful conclusions. And I think this really should be something that we should move towards, because the question is there. We have the data, we're just not linking it up.
So, you know, we talk about how representation and leadership really makes a big difference in really affecting systemic change, right, for underrepresented groups. So what about having more clinical trialists, and how would this affect, and how, or maybe what are some tools that people are using to increase, you know, or encourage involvement of people of color to be trialists, clinical trialists?
Absolutely. I think that there is a lot of work to be done at different stages, and in terms of recruitment as well as then retention in the clinical trial space. There needs to be, I think, education in terms of why this is important and what the evidence is for representation actually having a knock-on effect in terms of improving recruitment of minoritized groups. And I think that data is there. There is a lot of work that can be done on the ground in terms of patient recruitment at the grassroots level. And for example, where I work, we have patient information leaflets translated into different languages. We just seeing someone that looks like you is more likely to encourage people to enter trials. One of my colleagues, for example, gives talks on lupus in churches, in temples, in Sikh temples, Hindu temples, and so on, to improve awareness and to try and break down those historical barriers that some minoritized groups may have in terms of distrust into a clinical trial, and trying to dissipate those very deeply entrenched barriers that are understandable, but we do need to address in order to solve this problem, to improve recruitment to registries and clinical trials. So I think you're absolutely right. These problems are multifactorial. The solutions are also multifactorial. Improving the trialist recruitment and retention, which hopefully will also have a knock-on effect with respect to patients. And all of this is going to take funding and intention. So money and will, I think, is important.
So another question is around imaging. So ultrasound, subclinical GCA, and treatment and approach, and the validity usage of ultrasound of the temporal artery biopsy in patients who have GCA.
Sure. Yeah, I didn't go into ultrasound, and interestingly, in the ACR guidelines, ours differ from the EULAR guidelines. So I'll just speak on kind of the U.S. experience, where the training and experience in ultrasound is limited, although there are increasingly more centers that have this available. I think in the hands of a trained clinician or sonographer, this is a very useful tool that can be incredibly helpful. But I do caution the situations where I've seen where the sonographer may not have a lot of experience with giant cell arteritis. Certainly, they have a lot of experience in other vascular disorders, and make very preliminary calls about GCA, which clinicians may end up just taking for truth and not kind of doing additional workup that may be necessary. So I have certainly seen kind of incorrect ultrasound diagnoses. Similar with MRI, I think, again, this is an area that we need to ensure standardization and high quality information before we start implementing this in a disease that is really kind of visually threatening, and the consequences of missing it are very severe. So I think that this is the future. I think more vascular imaging is going to increase, but we just need to use it with some caution.
Yeah, we have the same problem with biopsy, right? It's only as good as the pathologist who's reading the biopsy. So we have to take into consideration the operator and the investigator.
Yeah.
Yeah.
And then just to throw another question in there, Rennie, for you, are there biomarkers in development that might get us past the need for tissue sampling and imaging? Anything, even if it's in the 10 to 20-year horizon, that might give us better access?
I know of studies that are ongoing to do that. We have a lot of high throughput assays to look at hundreds of different biomarkers and proteins and immunologic factors. I think this is in the future, though. Nothing that I imagine is going to happen anytime soon.
And then just to bring that back to an equity issue, right? And we saw this with our GWAS mapping and sort of a genetic construct behind disease. Yes, race may be important, but the problem is race is self-reported. And if I report as, what do I report as, right? My grandparents on one side are Irish, the other side is Indian, from India. The other side is, we've got stuff from Africa. So where do my genetics come from? So the fact that I present as Afro-Caribbean or Black doesn't actually become the surrogate for what my genes are. And this is true, I think, for so many people. Colleague of mine, he was identified as being Persian by one group, Hispanic by another, Mediterranean white by another, right? So because he looked like so many different things. So I think we have to be very careful when we use the word race to understand that it is a summary of features that we identify based on our collective experiences. and different people may present as a different race in different environments. So that having been said, there were just some questions about us being able to use race within our medical thinking, but to understand that the data is only as clean as the original data, so that the assumptions then are baked somewhat in falsehood. And so then this segues into biomarker generation, right? The same way we did genetic, derived therapies. If our biomarkers don't reflect all populations, then we end up sort of amplifying a bias in terms of the access to more advanced therapies. So this is something that will permeate every single thing that we do, whether it is in caring for patients, researching diseases, or developing therapies. And so this idea of equity is critically important for everyone, underrepresented or not, right? Because it's going to impact our data. This was an incredible discussion. I mean, we are so far over and nobody cares because there's so much rich content here. But I do want to be mindful of everybody's time. And so we're going to, again, a round of applause for our fantastic speakers, for the audience, for really sort of, there's even more questions. I'll sort of pop them up and maybe we can get a Q&A, about various therapies, but we might have to do a follow-up. Let's just leave it at that. This is absolutely wonderful. And I just want to say a shout out that Puja will be with us in Orlando live in July at our annual conference, giving us more provocative and evocative questions to consider. So thank you so much for that. So we're going to segue now into our wrap up. A reminder to do your post-test now that everything is fresh on top of the brain. If you can just take me over now to our wrap-up slides, and I'll give the closing remarks so that we can continue with enjoying our Saturday. But really just to thank everyone for being present, and then giving a few reminders. Yes, we are all over the world. These were just a couple of dots. We weren't able to fill everything in. From where folks are watching, we had just under 500 people registered for the summit, and at least half of those in attendance. And we had 23 community watch parties across the US and one in Rio de Janeiro in Brazil. So really, I'm happy to have some of our global chapters involved in our discussions and really joining us. So we are now live and open for registration for the September and December summits. And there we're going to continue these discussions. We touched briefly on the idea of lupus affecting populations disproportionately. Now we're going to bring in the younger folks, the pediatric as well as the adult, and look at some of the issues with access there and understanding the intersectionality, the multiple intersectionality that we face in some of our diseases. And this extends through for December when we look across our skin color spectrum. The watch party locations will be added as we get closer to those dates, but you can register now. Everybody has a virtual registration. You get to choose a watch party that's close to you as soon as we have those locations finalized. So please feel free to sign up now for more of this fabulous and fantastic discussion. For the AWIR 2024 conference, just to know that your all access in-person pass gives you access to a host of different activities. As Priya so graciously outlined, we will feed you to death. So the meals are all covered, and you get 3 months of access to the content on the web app so that you can claim your shimmy hours and really sort of engage with speakers from within the continental US and from without the continental US. So we're really excited to have and invite everybody to attend. So we're not going to stop by reminding you that there are so many benefits to being a member, a one-time lifetime registration fee, and everybody is welcome to join. We don't care how you self-identify, or even if you wear purple, although we highly encourage a little bit of purple somewhere. So, thank you so much for your time and attention. And on behalf of the AWIR board, our band of purple, powerful ladies, really sort of leading us forward, saying a huge thank you and enjoy the rest of your day. Thank you so much.